Well, good evening, everybody, and welcome to the latest installment of the Collaborative Pharmacy Practice webinar series. I'm Mike Acosta, Executive Director of the Tennessee Pharmacists Association. I'm excited to have all of you on the phone this evening to talk about the rollout of collaborative pharmacy practice in the state of Tennessee. This webinar series is the first in a couple of webinars about collaborative pharmacy practice. And is really intended to provide the folks on the webinar with information about what does collaborative pharmacy practice look like and what are some initial considerations that we should take into account as we roll out collaborative practice in Tennessee. This webinar series is being put on by the TPA Ad Hoc Ambulatory Care Collaborative Pharmacy Practice Committee, which is one of our largest and most engaged committees in the state, in the Tennessee Pharmacists Association. So we're really appreciative to that entire committee for their efforts on putting this together and helping us out with collaborative practice. We have with us this evening on the webinar someone that certainly is no stranger to the association and collaborative pharmacy practice. We're honored to have Dr. Mackenzie Calhoun on the webinar with us, who will be presenting on how collaborative practice has affected her daily activities and kind of how she's built her practice around the idea of collaborative pharmacy practice over the last couple of years. Dr. Calhoun, of course, is an assistant professor in the Bill Gatton College of Pharmacy at the East Tennessee State University, and specifically within the Department of Pharmacy Practice. She does hold an adjunct faculty appointment in the Department of Family Medicine at the James H. Quillen College of Medicine. And she maintains a clinical practice with the ETSU Family Physicians of Kingsport. She's certainly well versed in this topic and has a lot of insight to share. And so we're honored to have her with us. And we certainly are honored to have each of you with us as well. We appreciate the fact that you have limited time outside of work and certainly appreciate y'all taking an interest in collaborative practice and wanting to learn a little bit more about how collaborative practice will look in your practice. And so with that, I'm going to turn it over to Dr. Calhoun to kind of describe the program and the objectives for this evening. So Dr. Calhoun, you want to take it away?
Great. Thanks so much, Micah. Like you said, we really appreciate you all joining us this evening. We had a great discussion earlier with a big crew at the lunchtime hour. I would ask that if you're available to, if you don't care to type in the questions or the chat, maybe what kind of practice setting that you practice in, so we can kind of have a good idea of who we're talking to. But really this evening we have a couple just quick things that we want to cover, and then we want to make sure we answer your questions also. And so first we're going to talk about some different opportunities to develop collaborative relationships and help patients in this way. Micah is going to really go through as the title of the webinar describes, the nuts and bolts of the legislation. Excuse me. And finally, we're going to talk about the process for developing a collaborative practice within your site. And so if at any time you have questions, feel free to just type those in and we'll try to get to them. We can also share some of the discussion that we had earlier as well.
The idea behind collaborative pharmacy practice really came up as a result of discussions between our health systems. The concept of collaborative pharmacy practice is uniquely something that we've been involved in as a profession for over 20 years now, but the problem really arose to the level that we needed to address with legislation because of some interpretations that were made by legal departments and health systems that it basically said you really need something in statute and in rule that authorizes you to be able to practice in this way. Previous to this point, pharmacists had been providing collaborative pharmacy practice type of services through medical orders with individual physicians for individual patients. And so the discussion became, well, a lot of the services have advanced past maybe what medical orders really covered, and so we needed more definitive language in our law and in our rules and regulations so that we could really hammer out what collaborative pharmacy practice is going to be in the state of Tennessee going forward, and really how we can affect patients' lives in a much better fashion and be more efficient in our healthcare system through the use of collaborative pharmacy practice and other type of modalities. And so a lot of the impetus behind passing collaborative pharmacy practice arose from the need to have more definitive language in law that authorizes pharmacists to do certain care and services. And so a lot of the initiative behind collaborative practice came from about a year and a half endeavor, and a lot of credit for that goes to my predecessor, Bettina Black, who did work on collaborative practice and was one of the key drivers of this law. Our process internally at the association was about a year and a half. We engaged our members, we engaged the Tennessee Medical Association, and we, most importantly, engaged our physician practitioners to try to bring them in to try to describe what a true team-based collaborative environment might look like. And so over the course of the months leading up to the introduction of the legislation, we did work with the physicians in the Tennessee Medical Association and got feedback from the American Medical Association and other physician partners to try to figure out what this really should look like in practice, and that's where the law came from. And so it really was a joint effort and a joint initiative. It did become law July 1, 2014, and the rules just recently went effective February 20th of 2017. So that's essentially why we're all here this evening to discuss rollout of collaborative practice. So I'm going to turn it back over to Mackenzie to talk about some opportunities and payment structures that might exist.
Absolutely. Thanks so much, Micah. And as you can tell, it took a while for us to get here. And I think that that's a really important point, that we're all really excited to kind of start implementing 100% right now, but it took a long time for us to get here, and it may take a while for us to fully implement as well. I should have mentioned I brought a cold home from TPA winter meeting with me, so I'll try to mute before I cough it into the microphone, but please bear with me. So I want to talk a little bit about what is collaborative practice to me, and then some also just general opportunities that I think lie within this new legislation and kind of this idea behind collaborative practice. As Micah mentioned, my practice site is a family medicine practice. It's a residency teaching practice, so I work with 18 physician residents and 8 attending physicians, along with a big interprofessional team of great nursing staff, as well as a licensed clinical social worker and a clinical psychologist, along with a large support staff. And within my practice and within primary care and ambulatory care, across the state, really, some of the things that pharmacists are involved with myself, and then also colleagues that are in other practices similar to mine, would be comprehensive medication management. And what we mean by that is kind of really taking ownership of the pharmacotherapy for all of the patients that we're involved with. So this may be managing several of their chronic diseases, but also just kind of taking ownership of the whole regimen that a patient may be on. Excuse me. A couple terms that are going to come up. One is accountable care organizations, and my practice is a part of an accountable care organization, which is several physician groups that kind of get together and work with payers to do some risk sharing and some unique payment models for quality. And with the Affordable Care Act, and then I watched or I listened to several hours this morning of debate in the House on what we think will probably be the new legislation. And a theme in both is that we would like to be paid for quality instead of quantity of care. So instead of being fee for service, to be paid per patient or per for the quality of care that we give. And one way that we are already doing that is through accountable care organizations. And what this means at the practice level is for our patients that are part of the payers that we have negotiated with, we are kind of judged and graded as a practice based off of how many quality measures that we meet for those patients. And so these are things like A1C goal, blood pressure goals, colorectal cancer screening, appropriate use of a statin on board. And so these, when a patient is not meeting this quality measure, they call it a gap. And we talk about closing the gap, meaning we're meeting these quality measures with patients. That is something that I do on a daily basis while I'm there, but have one day of clinic that's kind of specifically dedicated to really targeting the patients that have a lot of medication-related problems and have a lot of gaps that we need to close. And so I think going forward, there is a lot of opportunity for pharmacists as the pharmacotherapy experts that we can be involved in helping to increase the quality and closing those gaps. Some other areas of practice would be things like annual wellness visits. I want to give a shout out to Aaron Garst, the executive resident at TPA, who recently got a grant to implement a unique practice model that really could be upscaled, where he will be working at a physician group, with a physician group, doing annual wellness visits, which lots of people are doing, and it's paid for separately through Medicare. And then outside of that, there's something called chronic care management. And the neat thing about chronic care management is we're just going to, as a system and as providers, get paid for a lot of what we're already doing. And that's things like keeping constant contact with the patient, that's whether it's on the telephone or in person, making sure they're getting their refills, making sure that they're being monitored appropriately. And so that's something that Aaron's going to be doing, is working face-to-face with the patient and with the physician, and then take from that relationship, kind of taking ownership of the chronic care management after that. Some other things that kind of can fall under this umbrella of collaborative practice would be like insulin pump management or training. Also, something that I do once a week is transitions of care. I have a transitions of care clinic, and this would be for any patient that's been in the hospital or in a psychiatric facility or a skilled nursing facility. We have to do a few things to get paid a little bit differently, and actually it's pretty significantly more than just a normal office visit. But it's things like follow-up within 2 days, and we see them within 7 days. A medication history and medication reconciliation. So offering them community resources, just really making sure that transition happens well is really what's involved in transitional care visits. I think there's some other unique opportunities that kind of fall from that, and that might be a little bit more translatable to various settings. This is things like things we're already able to do, like immunizations and MTM. I think that we're doing a really good job in most places and in most pharmacists and pharmacies, but we still have a lot of opportunity to really take ownership of those things, that we are the MTM people and immunizers. Also, I know there are some outstanding diabetes education programs that are happening in community pharmacies across the state, but also within health systems and primary care, so really all settings. I mentioned the insulin pump management. I think insulin pump training, we have some certified trainers, pump trainers, and that would certainly be an opportunity that doesn't necessarily have to happen within the primary care setting. Continuous glucose monitoring, long-acting antipsychotic injectables, other kind of once-weekly or regular meds, and the monitoring that can happen along with those. Something that I had to make an appointment today is my insurance requires biometric screening. That could also certainly happen within a variety of settings. And then I mentioned the chronic care management that payment models are already being developed for. And while we're talking about payment, I want to go ahead and give a teaser for, this is the first of a webinar series for the entire year. we're starting with the nuts and bolts, but then May 4th is going to be starting a collaborative practice. July 6th we'll be documenting and evaluating. September 7th we'll be marketing that collaborative practice and some payment models that go along with that. And then in November we'll finish out this series with some examples of collaborative pharmacy practice. And so while we're going to touch on a lot of things this evening, I wanted to go ahead and maybe put those dates on your calendar, and we'll make sure that they make it to the TPA calendar as well. But there's a variety of payment models, but I think more so than the things that are established, there's a lot of people working really hard, Micah included, to develop these payment models and working with the payers and with the insurers and also with the health systems to develop these. And so right now there is some fee-for-service opportunities, but I think maybe the greater area of opportunity for payment would be kind of the same thing we were talking about for the health system in general. Of we do some risk sharing, and if we improve quality, then we get paid. And so developing relationships with whether it's a health system or a large physician group or an accountable care organization, and developing agreements with them to help them out in some of the things that I was discussing, and kind of developing payment models based off of how well and how many patients that we're able to help take care of. So that's just kind of hinting at the payment. I want you to know we know that that's one of the first questions, and we're trying to also develop some additional resources to kind of help do the step-by-step of figuring out what the payment model is going to be. So we'll talk certainly more about that in the coming webinars as well. So let's dive into the legislation, and I'm going to turn it over to Micah so he can really walk through both the legislation includes, as well as the rules and what should be included into a collaborative pharmacy practice agreement.
Thanks, Mackenzie. And we'll make these slides available after the program, and the webinar is actually being recorded, and so we'll put the recording of the webinar up if you need to go back and look at some of these things in more detail later. But as you can tell, and as I referenced before, July 1, 2014, collaborative pharmacy practice became law in the state of Tennessee, and then February 20th of this past month, collaborative pharmacy practice rules went into effect. And those rules really defined how those agreements are going to be looked at by the Board of Pharmacy. The law itself is the authorizing language of who can enter into an agreement and what that agreement should look like, and some particulars. And the rules are really how do you implement that in your practice. And so we'll be walking through both the law and the rules, including the definition and some of the changes that have been made to the practice of pharmacy. And I want to encourage everybody on this webinar to think about pharmacists in our role as truly medication experts. When we talk about collaborative pharmacy practice, I think a lot of times people use the model of mid-level prescribers, and so when we talk about collaborative practice, we might reference a physician assistant or a nurse practitioner as kind of the model for collaborative pharmacy practice. But in terms of what we bring to the table as pharmacists and pharmacy professionals, we bring a wealth of knowledge and experience in medication therapy, and truly as that medication therapy expert, we need to think of ourselves as specialists, uniquely trained and qualified to be able to provide the types of services that help patients achieve better outcomes through the use of medication and the optimal use of medication, really. And so when you look at a lot of the discussion items that Mackenzie brought up around payment reform, the entire focus of payment reform is really on how to optimize the use of medications and make sure that patients are getting the best quality possible and the best care possible, and they're reaching their goals of therapy. And so I think a lot of the discussion really has been, and if you look at the 10 Care episodes of care that they put into place, and that they're rolling out. There are 75 episodes of care, and nearly half of them, or 36 of them, specifically deal with medication therapy as a driver of those better outcomes for patients. And so I think there's a lot of goal-oriented care that we can help contribute to as pharmacists, and really to play a part on the healthcare team through collaborative pharmacy practice. And so I encourage you all to think about collaborative practice as we walk through, and think about the types of patients that you might be able to provide care to using a collaborative pharmacy practice agreement. Truly, it's not going to look the same in every practice environment, and so each of your practices and each of your agreements is going to be different. It's going to look differently based on the physicians and the prescribers you partner with, and it's also going to be different based on the groups of patients that you have in your patient population. And so I kind of want to preface that discussion, our discussion this evening, with that disclaimer. When you look at who exactly can enter into a collaborative pharmacy practice agreement, it's essentially a voluntary agreement between one or more prescribers and or one or more pharmacists that are licensed in the state of Tennessee. And the collaborative pharmacy practice agreement is a written and signed agreement between the two of them, which basically outlines the scope of services. It outlines the types of services and the types of patients that will be essentially benefiting from this agreement. Whenever you look at the outline of what types of services and what scope of services pharmacists can provide, one of the changes that happened in the Tennessee Code specific to the practice of pharmacy is the recognition that pharmacists can essentially order laboratory tests and prescribe prescription drugs. They can do the ordering of laboratory tests or prescribing of prescription drugs through two modalities right now in state law. The first is a medical order by an attending prescriber for each patient, or pursuant to a collaborative pharmacy practice agreement, which is jointly agreed upon by the pharmacists and the prescribers. And so there is your authorization to be able to prescribe, and including selection, initiation, modification, discontinuation of medications. But it has to be pursuant to either a medical order or a collaborative pharmacy practice agreement, which is agreed upon between you and a prescriber or prescribers. Now, it's important to note, we got a lot of questions on the 12 o'clock webinar about CLIA-waived testing and using preventative health tests. And it's important to note that pharmacists currently under practice can also conduct and assist patients with tests approved for home use, which is essentially the state's CLIA-waived test list. And so that's essentially, that's part of this, but you can still do that without a collaborative practice agreement as long as you have CLIA waivers and the proper forms filed with the state of Tennessee. Now, whenever you look at the specific language around prescription order, this does authorize, and again, when you look at the definition in the Tennessee Code around prescription order, it does include in there pharmacists pursuant to a collaborative pharmacy practice agreement as being able to prescribe prescription drugs. And then there's a lot of language at the bottom you can note about pharmacists and their ability to prescribe and then to convey verbal orders back to other pharmacists to be able to essentially affect patient care. And so there is a lot of allowance in there for pharmacists to prescribe to other pharmacists too. And so that's really a lot of the code changes that are in statute at this point. Again, who can enter into a collaborative practice agreement? It's important to note that it's between pharmacists and prescribers, but you can enter into an agreement between pharmacist and a chief medical officer, medical director, or designated physician in an organized medical group. So for those of you that work closer to larger medical groups, you may want to partner with the larger medical group and include all of their prescribers within their medical group in order to cover more patients under this collaborative practice agreement. So that's something for your future consideration. Scope. The collaborative pharmacy practice agreement does need to define the nature and scope of the patient care services you're going to be providing. Whenever you look at the scope that you may be providing, it really does fall within the scope of the authorizing physician. And so you're going to want to partner, let's say if you want to do diabetes management, you're really going to want to partner with those either an internist or an endocrinologist, somebody who has within their defined scope the practice of managing patients with diabetes. And so you're going to want to focus your efforts in collaborative practice around those prescribers that do have certain scopes in order to maximize benefit to patients. You do have to communicate back with the prescribers within 3 business days, and that is a requirement in here. So if you do make changes to medication therapy, you do need to change those orders and communicate those changes back to the prescriber within 3 business days. Now, when you look at communication, if you're in Dr. Calhoun's situation, you may be integrated in the e-health record, and so purely just providing that doctor's note back, the physician's SOAP note or whatever it may be, back to the physician about the changes would suffice for communication. It doesn't note in here that the physician or prescriber has to verbally or physically or in the chart acknowledge the change, but you do have to document it and communicate it back to the prescriber. Physicians are authorized under this law to hire you as a pharmacist in their organized medical group. In the case of Dr. Calhoun, she does practice within the Department of Family Medicine, and so you essentially could practice in that environment, like her environment where she's hired on to provide the care within the medical group. It's important to note that you cannot employ a physician specifically just for maintaining, establishing, or entering into a collaborative practice agreement with a patient. And so you can't just pay a physician to sign your agreement. However, you can pay a physician to do quality assurance reviews, and we'll talk about those quality assurance reviews in a little bit, but you really do need to, if you're employing a physician, make sure that your language is for the quality assurance and not just to sign your agreement. If you partner with mid-level prescribers, you're going to need the authorizing physician that has responsibility over those mid-level prescribers to also sign the agreement, and the services within the mid-level prescriber scope need to be also within those services of the supervising physician. You do have to maintain a copy of the written collaborative pharmacy practice agreement on file at your practice, as well as whoever you're partnering with prescriber-wise. They need to maintain a copy on their practice site as well in order to maintain compliance with the law. And you do have to make that available to the boards, whether it be the Board of Medical Examiners. If it's a physician you're partnering with, they need to have an agreement where they can make that available to the boards upon review. And if the Board of Pharmacy walks in to your practice and wants to see a copy of the collaborative practice agreement, you do need to have that on file. You do need to review your collaborative pharmacy practice agreements. The law requires at a minimum biennially or every 2 years. I would think a good practice would be more frequently than that, considering the fact that whenever you look at guidelines, diabetes guidelines come out every year, so you may want to review your collaborative practice agreement based on those guidelines coming up and update those more often. But the minimum requirement is every 2 years. We'll talk about where these definitions fit into the rules at some point as we go through. But there is a definition for active practice, and the active practice definition is paid, unpaid, or volunteer activity that requires a pharmacist license for at least 2,000 hours within a 24-month period, and I'll explain why that's important in a bit. The authorizing physician has to have a direct provider-patient relationship. We'll talk about a couple scenarios where you don't have to have a direct provider-patient relationship in a bit, but the physician does have to have that direct provider-patient relationship for certain activities that you provide under this collaborative pharmacy practice agreement. They have to be a supervising physician over the APRN or the PA that is also in the agreement. And so if you're contracting with mid-levels, you also have to be contracted with that supervising physician, as I mentioned before. And then also if they have a specific specialty, like if they're an endocrinologist or if they have a specific medical specialty that you're partnering with them on through a collaborative pharmacy practice agreement, they need to have recognition and certification by the Board of Medical Specialties, the American Board of Medical Specialties, or the American Osteopathic Association Bureau of Osteopathic Specialists. And so that is important if you're going to focus on specialty areas. The definition, there's the definition of collaborating prescriber, again reinforcing the fact that you have to have a direct provider-patient relationship, and there has to be a plan of care that's prepared on behalf of the patient by that collaborating prescriber. And that's important to note, and Dr. Callahan will allude to. Our goal here is to really be a part of the healthcare team to manage medications and to find a way to manage patients and their chronic conditions, not necessarily to diagnose. That's certainly, I think, something where we can partner with physicians in a very real way. There's a definition for hospice patients in there, and I think it's a pretty standard definition. One of the things that we did work very closely on was the definition of institutional-based pharmacy setting. So under the rules, the definition of institutional-based setting is institutional facilities or long-term care facility or an academic healthcare institution where the pharmacist is responsible for the care of patients within that facility, including prescriptive practices under the terms of collaborative agreement. Patient care services, again, it's whoever you're partnering with, whether it be an authorizing physician or prescribers that are maybe under that authorizing physician's purview. It has to be within the professional training experience of the healthcare practitioner, be covered under the collaborative pharmacy practice agreement. A definition of routine scope of practice and services is also outlined, again, really focusing on the focus of routine scope and practice being involved, the authorizing physician having that supervising scope so that you're working in line with that physician or mid-level prescriber that does have an expertise in a certain area. And there's the definition for unencumbered as well. So now we get into the actual who can provide collaborative pharmacy practice in the state of Tennessee. And so whenever you talk about the definition of active practice of pharmacy, the two types of pharmacists that can provide this is pharmacists who have a Doctor of Pharmacy or PharmD degree, and then also pharmacists that have a Bachelor of Science in Pharmacy and have been in active practice, which is, again, 2,000 hours over a 24-month period. So essentially, any pharmacist practicing and licensed in the state of Tennessee can enter into collaborative pharmacy practice agreements as long as they've met the continuous active practice requirement. Other minimum required elements of a collaborative pharmacy practice agreement is the names and titles of collaborating prescribers, the list of authorized care and services provided, how the documentation and communication will be provided. So again, if you're integrated into a larger health system, it may be documented through an EHR or health record, or if you're in a hospital or health system setting, it may be just documenting in the patient's electronic chart. But if you're in a community setting, you may need to communicate those changes by fax or other prevailing method. If you have things like direct messaging, one of the things that we're working at here at the association is integrating pharmacists into the state's direct messaging component so that maybe we can find a way to communicate these back electronically through a secure method as opposed to doing a fax method. You also have to have an override clause. So physicians maintain the ultimate authority for changes made under collaborative pharmacy practice, and so there has to be an override clause that basically states that in your agreement. You also need to have terms of expiration, modification, and termination of the agreement and how those will be handled. There's also automatic exclusions, which obviously may have something to do with encumbered license, and so if you don't have an unencumbered license, there may be an exclusion in the collaborative pharmacy practice agreement for you to provide CPPA types of services. And then a quality assessment, and there's a routine review required, and this is required for all providers that essentially provide care according to these types of agreements, that the supervising physician will review at least 5% of the patient's charts. And so there is a requirement for quality assessment. And so you can employ a physician to do those quality assessments or quality assurance reviews, and that's how you would go about employing a physician as part of collaborative practice. Notification requirements for collaborative pharmacy practice. You do have to properly execute a collaborative pharmacy practice agreement, and you do have to file a written attestation with the licensing boards for all practitioners participating in the agreement. I've talked to Executive Director Dillard at the Board of Pharmacy, And the current protocol for written attestation is you file a one-page written attestation with the licensing board, just basically letting them know that you've entered into a collaborative pharmacy practice agreement with prescribers. You don't have to file your entire agreement with the board. They certainly don't want that. They do want a record of who is participating in collaborative pharmacy practice in the state of Tennessee. So you do need to file that written attestation with the Board of Pharmacy. And you can do that by faxing just a one-page attestation over to the proper licensing board. Patients or patients' authorized representatives must sign a general consent. Essentially, especially in health systems, there is a uniform patient consent form that patients will fill out on the front end of treatment. And it basically says you agree to be seen by these providers for these types of services that are offered under this program or offered at this healthcare facility. And that specific the specific provision about general consent really only reflects that you're making a statement that patients agree to care provided by a team of healthcare practitioners, including physicians, maybe nurses, physician's assistants, APRNs. You just have to add in pharmacist as another provider into that patient's general consent form. And you really do have to have the agreements. Everybody who's in the agreement needs to have a copy of the agreement. You can share that electronically through your e-health record if you have those, or physically you can mail those, fax those, but everybody needs to have a copy of that agreement. And you need to have the supervising physician sign and approve the CPPA. And so whenever you look at non-institutional based pharmacy settings, the attestation has to include the formulary and categories of drugs and services authorized by the agreement. And that specific attestation has to be filed within 30 days following the effective date of the agreement. And so as soon as you get all parties to agree to the collaborative pharmacy practice agreement, you do need to file that within 30 days, which includes the formulary of categories of drugs and services authorized. And so one of the things that the law specifically addresses is professional liability insurance. And so the law does require pharmacists, physicians, advanced practice nurses, physician's assistants, essentially anybody who's entering into these agreements to carry a policy that includes at least $1 million in professional liability insurance coverage per occurrence. There's a couple of things that you need to make sure on your professional liability insurance that you have. Number one is you need to have coverage 24/7, 365. So everything that you do as a part of this collaborative practice agreement, whether it's on a Sunday morning or Wednesday afternoon, needs to be covered under your liability insurance. The other thing, part two, is you need to ask your professional liability insurance carrier if all scope of services provided in the state of Tennessee are covered under that policy, and to make sure that they cover state scope of practice, including collaborative pharmacy practice agreements. And one of the questions that has come up that I want to address before we move on is that certain providers, because the law went effective 2014 and July 1, you could provide collaborative pharmacy practice. A lot of our pharmacists have already entered into those collaborative pharmacy practice agreements with prescribers for collaborative pharmacy practice. One of the things that we hope to launch in the next couple of weeks is a specific dedicated page for members on the association website that focuses on collaborative pharmacy practice, including examples which are currently up on the Tennessee Society of Pharmacists page on the TPA website. But we want to launch examples of collaborative practice. We want to put this webinar up for people to access. We want to put these slide decks up so that people have information, and also to provide a checklist for you to go through your collaborative pharmacy practice agreement so that you can ensure that you have everything that you need. Another service that I would offer up, and I hope that I'm not speaking presumptively, but our TPA Ad Hoc Ambulatory Care Collaborative Pharmacy Practice Committee is committed to making this work in an organized fashion. and really rolling this out as a standard of practice and making sure that everything is up to snuff in terms of state rules and laws. And so they're really taking the lead on this, and so we hope to add more resources. But you can certainly contact Dr. Calhoun or myself. We'd be happy to go through these and see if we could share more information with you about your agreements and what those may look like. So we'll offer that up as a service, certainly, to help you out. A couple of the discussions that we had on what does the scope not include for collaborative pharmacy practice. Essentially, collaborative pharmacy practice is a relationship between the provider or prescriber, the pharmacist, and the patient. And so a lot of the language in here preserves that triangle of care between the prescriber, the pharmacist, and the patient. And so collaborative pharmacy practice really does involve a patient-specific, drug-specific, disease or condition-specific plan of care that's provided by the prescriber. And so you want to work one-on-one with the prescriber to get that plan of care, to put in place your own plan of care, and to help keep the prescribers up to date on what types of services you're providing. It's important to note that the exception to that rule for the patient-specific, drug-specific, disease or condition-specific, the exceptions are immunizations and screenings and testings which don't require that patient-specific plan of care. Another thing is the statewide collaborative pharmacy practice agreement with the chief medical officer for the provision of opioid antagonists, which do not require patient-specific plans of care. And so those are important exceptions to the rule that I'd like to bring specific note to. The other discussion that we had a lot of information and input on at the board was the idea behind provision of collaborative collaborative pharmacy practice services for controlled substances in non-institutional settings. A lot of discussion was had about our current prescription drug abuse epidemic that we have in the state of Tennessee. And the original language read management of controlled substances in non-institutional pharmacy-based settings. And so basically saying community-based pharmacists could not provide management of controlled substances. And we push back a bit on that because our pharmacists, especially in our community settings, are often the front lines in terms of managing controlled substances and preventing prescription drug abuse. And so the language has really been narrowed to prescriptive authority for controlled substances. And so if you practice in an institutional-based pharmacy setting according to that definition, or if you practice where you might provide care for hospice patients, you do have the authority to prescribe controlled substances for those patients. But in those non-institutional-based pharmacy settings, essentially your community settings, currently the scope of collaborative practice does not include the prescribing of controlled substances. Now, I think that we'll probably find that there's a lot of other services, again, that pharmacists provide, including getting patients off of controlled substances, reducing doses, making changes to their therapies that would warrant pharmacists to need a greater role in those non-institutional based settings related to collaborative pharmacy practice around controlled substances. And so that's something that we'll certainly be looking at as we roll these agreements out. Again, you do need to be able to make these agreements available to the board upon request. And then you do need to make sure that you have an appropriate area to be able to provide confidential communications between yourself and your patients. And certainly that area can be in-person, telephonic, or other approved methods for those consultations, but you do need to have a private area to maintain confidentiality with patients. Physicians maintain the ultimate responsibility, including their advanced practice nurses and physician's assistants that are maybe parties to the agreement, and they do need to maintain that physician-patient relationship. And then patients or prescribers should be available at all times through direct telecommunication for consultation, assistance, and direction, or they can make arrangements to have a substitute physician to be available for those consultations. Pharmacist prescribing, all of the things that pharmacists check for currently on prescriptions now to maintain compliance and prevent those pesky audits from occurring, pharmacists will now be responsible to include on their prescriptions. And so if you're prescribing, you want to look back over the rules and regulations around required elements for prescriptions so that you can be in compliance when you do write prescriptions for prescription drugs. Also, there is a requirement that if you do maintain a DEA license, if you prescribe controlled substances, and especially in those institutional-based settings or for hospice patients, you do need to take the state-required 2 hours of continuing education related to controlled substance prescribing biennially, and that's something that certainly we work on and offer to other health professions, and would be happy to make available to pharmacists as well over the next couple of months. And so that is a specific requirement of this law. So as you think about collaborative pharmacy practice and the rules and the laws, I would encourage you to ask questions through the chat box. And I'm going to turn it over to Dr. Calhoun to kind of bring it all together and talk about lessons learned and key questions that you might want to ask. And so as she's talking, think about how collaborative practice might improve efficiencies and improve patient care in your practice. And so Dr. Calhoun, I'm going to turn it over to you to kind of bring it all together.
Great, thanks so much, Micah. As Micah kind of just went through the process, and thanks so much again, because he's done that now twice today, and I just can't imagine how exhausting that must all be. But I just rewrote my collaborative practice agreement with one of my colleagues here at ETSU, Brooklyn Nelson, and we have similar practice settings, and we decided we were going to try to write an agreement that would be roughly interchangeable for all of our ambulatory care faculty at our college. And so I just went through this process of redeveloping my collaborative practice agreement. And that's where I came up with these questions, these 5 questions at the top of the slide, that I think kind of it would be a good idea to answer these questions, or at least think through these questions before you do too much, before you move too forward. The first thing, what kind of services do you want to provide? Excuse me. And I said this a little bit earlier, but I know we all are gung-ho, ready to go, ready to practice at the top of our license and implement all these things. And I think something in inverse to when we're asking for legislation, and I remember Bettina telling me, and Micah too, that you got to ask big because you know it's going to get smaller. We don't have to do that. So this is legislation now. We have board rules now. This is around for a long time. And so I think what's important is figure out what you can do well and right, and start there. So that might be anticoagulation monitoring. That might be maybe the chronic care management for a small subset of patients. But there's a lot of risk and responsibility that comes along with providing these services, and so I think it's really important that we think through what services you want to provide, and maybe you start with 1 or 2 things, and then kind of develop it from there. I think you also gain a lot of credibility with the providers that you're working with when you do that. The second thing is what patients would benefit. Of course, that is our primary goal, is to help patients, and so is it with 1 prescriber? Is it with diabetic patients and you want to work with several different prescribers? Is it the patients that already come to your community pharmacy? And so identifying what patient group, because that may help identify what physicians or providers that you would want to be within in this collaborative practice agreement with. Micah talked pretty extensively about the documentation that's required, and I really can't overstate this. That documentation is so important. I'm really lucky in that I get I'm within the practice, and so we use the same EHR across our entire department. And so essentially, as soon as I document, it's viewable by the providers. So figure out how that documentation is going to happen. One thing I would mention is you might be able to get access to the electronic health record even if you're not in the same site as the people you're going into the agreement with. Logistics, and so there's a laundry list of the logistics that really have to be thought through, but kind of where you start is how's the communications going to happen? For those that were at the TPA Winter meeting last weekend, something that my colleague, Dr. Gilbert Green, one of the physicians I work with, and I talked about was that communication and relationship building is the number one thing that makes this successful. So how are you going to deal with the logistics and then the communication, and how who calls who? Where do patients go? And then developing the formulary. For my practice, we have primarily Medicare and Medicaid patients, and so I kind of pulled the formularies of the payers that most of my patients fall under, and I modeled my formulary roughly after those formularies because that would be the best benefit to my patient population. And so it may be much smaller to start with. Maybe it's going to be insulin pump management. So insulin is the only thing that needs to be on your formulary, and that's fine. Keep in mind, you can always continue to edit these, and so just because you start with something smaller, that doesn't mean that you can't expand at any time as your comfort level and credibility and education and training kind of match whatever it is that you want to put into your agreement. And then communication and education. I mentioned communication, but it really has to be the cornerstone of all your plans. Needs to include how am I going to communicate with both the provider that I'm in an agreement with as well as my patients, and figuring out how to make that as seamless as possible. And then finally, education, and just like you all that have taken the time to join us this evening are educating yourselves on kind of what's involved in this process and in this legislation and in the agreement itself. That's not something that even all of the pharmacists in Tennessee are well versed in and are familiar with. And so we as a profession are going to have to do a lot of educating as we implement these collaborative practice agreements and this kind of level of advanced pharmacy practice. And so as you're implementing a collaborative practice agreement, make sure that your staff is well educated in what's going to be the process and the logistics involved, but also why are you doing this, and what does the legislation allow you to do, along with the collaborators. And so this did not make national news as much as I wish it would have, or maybe even, front of the Tennessean news. So probably a lot of the collaborators don't even realize that this is something that they're able to do. So a lot of education of the providers that you're going to be in collaboration with is going to be important. And then finally, of course, patients. And so the patients might get a little confused as well as we're kind of changing their process. But really, the three priorities I think that we have to keep in mind when we're moving forward with this is that patient safety has to remain the number one priority. Number two would be the patient outcomes and making sure that we're improving quality of care given and improving access to care and the amount of care, and then we have the outcomes to support it. And then third would be expanding our profession. And so I think we have to keep it in that order and keep in mind that patient safety has to come first, and then we need to be tracking the outcomes. Please let us know if you're already in a collaborative practice or doing something innovative. I don't think we give ourselves enough credit as a profession, and all of those things are really helpful for Micah to know as he's going to lobby with our legislators to tell what pharmacists are doing and how we're helping to take care of Tennesseans. So please let Micah know, let me know, any member of the Collaborative Practice Ambulatory Care Ad Hoc Committee or the TSP, Tennessee Society of Pharmacists. That's something that we talked about last week. We just really, if nothing else, need to kind of start gathering who are doing some of these things already so that we can provide the highest level of education and resources for all of the pharmacists within the state. So again, please let us know if you're already doing some of these things. Also, we would love feedback on what kind of resources that you need, what questions that you have. Micah mentioned the document that was created by our committee last year, and it's available under the TSP part of the website. But these business rules, or these this guidance document, was developed by a group of about 10 practicing pharmacists that are either under a collaborative practice agreement or probably soon will be, that are practicing in an environment that's kind of conducive to these relationships. And so we really worked very hard to develop this document to make sure that it's a very usable living document, and so it'll probably continue to change, but it will go through kind of some of the business models, some of the documentation. It gives we have examples of collaborative practice agreements, and formularies, and kind of just definition of terms, and some things like that that can really help people that are kind of just now starting to develop their own collaborative practice relationship. We also, as I mentioned, have the webinars coming. We have done educational tracks at summer meetings, and we'll continue to do as much education in a variety of areas and topics as you all want. So please stay in contact, let us know. Also, any questions that you have, of course, Micah or I would both be happy to answer now or at a later date. And so we just really appreciate you all taking the time to join us this evening. And with that, I will answer any questions that anybody has, or if Micah has anything else. Good.
I just want to mention one more thing as the questions are coming up. You know, as we look toward pharmacists playing greater roles in the services that we know that y'all provide and can provide, and do provide, we are looking for ways to incorporate y'all into the medical provider networks. And the reason at the state level that we're focusing on that is because there has to be some type of mechanism to recognize you as a provider. There is legislation this year that is working its way through the state legislature that would essentially prohibit managed care organizations from excluding pharmacists based on your qualifications, and specifically excluding you. They would not be permitted to exclude you from their networks for reimbursement, referral, and recognition as providers. And so at a state level, we're looking to incorporate you more into the medical program, because that's really where most of the savings comes from. And so at a state level, we're looking for ways to incorporate you in. At the federal level, there is legislation, again, that was reintroduced this year to recognize pharmacists as providers within the Medicare program and Social Security Act. And so I would encourage you all to get engaged on that. Also, if you do not have an individual NPI or National Provider Identifier number, I would encourage you to get your individual NPI, because that's how most providers will sign up in provider networks. And so things you can do right now is go ahead and get your NPI number as a provider. And then on top of that, we did find out earlier this week that TennCare has added pharmacists through its medical provider enrollment process. And so online, you can enroll as a medical provider. Currently, I believe it's limited to immunizations, but that certainly could expand, and we hope that it will expand with more collaborative practices going up and more services being provided by pharmacists. And so we are really trying to find a way to not only just put this into practice, but to make it possible for you to actually provide these types of care and services to patients and be recognized and reimbursed for them. And so that's certainly a goal of the association over the next couple of months, is to work with our MCOs to incorporate you in as providers for the types of services that you're certainly qualified and authorized to provide under collaborative pharmacy practice. And so that's something that I would encourage you all to all do before you move forward with a lot of these things, is to get your infrastructure. There was another question specific to listing individual medications versus classes of medications, such as DPP-4 inhibitors or you know, SGLT2s, or do you want to list specific classes of medications versus individual medications. I would encourage you to have those discussions with the prescribers. If there's certain things if you wanted to do oral diabetes meds, including this type of medication, or if you wanted to list out every single medication that you can prescribe, that's probably going to be a comfortability level with you and the authorizing physician. Mackenzie, do you want to add to that?
Sure. I can tell you what I did, which was I listed out classes. I didn't go beyond the class level, except if there was only one drug in the class. So for example, for the oral diabetes medications, I did list out, I think I listed metformin by itself, but then I did sulfonylureas and glycides and DPP4s and GLP-1s and SGLT2s. For the insulins, I did list out all of the insulins. I didn't just say long-acting. And so I think, yeah, it is, I did a little bit of both. For the statins, I think I just wrote out HMG-CoA reductase inhibitors. And so if there would be any question as to what drugs you're talking about, then I think I would go ahead and list out the drugs. So for example, instead of just saying long-acting insulin, I think I would list out all of the long-acting insulins, since if you want to include the concentrated ones, or so if there would be any question, then I think I would go ahead and list out each one specifically. But if it's kind of a well-known, like the statins, I think you can kind of list those as one whole one. Good question.
And I think as collaborative pharmacy practice emerges in the state of Tennessee, I think we're going to see a lot of innovative models of providing care, and a lot of opportunities for pharmacists to really play a more active role as providers within the larger healthcare system. As I mentioned, with the implementation of these episodes of care models and our national focus on providing optimal patient care, which produces those optimal health outcomes for patients and really reduces cost, I think pharmacists will only play an increasing role in achievement of those goals. And so we're really excited to see collaborative pharmacy practice roll out. We're excited that all of you have been on this webinar tonight, and we hope that you'll stay engaged and you'll communicate early and often about what you're doing and the great things you're doing to improve patient care in the state of Tennessee.
Absolutely.
I'm not seeing any additional questions, but certainly contact Dr. Calhoun or myself or anybody on the TPA Ad Hoc Ambulatory Care Collaborative Pharmacy Practice Committee if you've got specific questions about how to roll this out. They'll be more than willing to help you out. And I think as Dr. Calhoun so eloquently put it, we're looking for a way to roll this out that is first focused on patient safety and focused on quality of care, and really changing the practice of pharmacy for the better and ultimately for our patients. And so I think that's certainly a message that we want to carry through. But I don't have anything else to add. So I'd like to thank you all for being on the webinar this evening, and I'll turn it over to Dr. Calhoun to make closing remarks.
Absolutely. No, I agree. I think something I realized last week when during the TPA winter meeting is there's a lot of excitement within our profession right now, specifically in the state of Tennessee. And I think we all owe Micah, thank you, as well as Bettina and the people that have worked a long time to get us to where we are, because things are changing within our profession, as I'm sure all of you know, and I think it's for the better, especially in the state of Tennessee. And the more I'm out of the state, the more I realize just how lucky that we are. So please, again, let us know how we can help. We are committed as a committee, and I think as an association, we're committed to making sure that this works and that this becomes something that lots of patients are going to be ultimately really benefit from our involvement in their care. So with that, I will say good night from East Tennessee. Please let us know if we can help you all in the future. Have a great evening.